Sounds
You
good.
just edit and make me look thinner? Thanks.
We could do that.
Sideways.
Just anybody that hasn't joined before, my name is Justin Gardner. I'm the Wilderness Medicine Fellow with Roanoke Memorial Hospital, the Carilion System in Virginia. This is the Virginia Tech Carilion Journal Club. It started in September. We've covered a variety of topics. This is our second event that's officially fostered by the WMS and offers free FOM credits for students of any healthcare field and residents. So we like to basically have this for and by students and residents. So students and residents give the presentations and then we discuss, and I just kind of monitor and moderate and keep time flow. And we have experts join us and kind of add their expertise. So everybody's ready. Go ahead.
Awesome. So can everyone hear me, just to be sure? Luddite tendency is starting to show already. Wonderful. So my name is Ditya. I go by Diddy. I'm one of the 4th years of Virginia Tech Carilion School of Medicine over in Roanoke. And the topic that I'll be presenting on are the pit viper guidelines. And there are a lot of them. So I'm going to try to be as accurate as I possibly can, but please, if you have any questions, feel free to ask. And if you know better, please chip in. But with that, let's get started. So there is a lot going on with these guidelines. Right here, can you see my cursor okay? Right over here. All right, cool. So these are the guidelines that I will be referring to, and we're just going to run through all of these. And I'll try to include some cool pictures here and there. So first off, epidemiology. So as you can see, snake bites are a worldwide problem. There are as many as 9,000 per year over in the United States. Approximately a third are venomous. And that's really almost entirely the pit viper family. And that's kind of the main motivation for this presentation for these guidelines. And even then, the statistics are not necessarily the most reliable. Many bites are not reported to poison control. And consequently, they're difficult to keep track of. So a lot of these are actually estimates, or underestimates rather. So the first question really, at least for me, before starting this presentation, I had zero idea what pit vipers were exactly. So kind of going back to our biology 200 class, you have Viperidae, which is a family, and these are venomous snakes with long folding fangs. And it kind of splits into 2 subfamilies, and we'll mostly be focusing on the Crotalinae right over here. And those constitute both old and New World pit vipers. So basically, the main reason why I want to delve into this at all is to recognize certain attributes of pit vipers. Firstly, you have these characteristic heat detecting loreal pits. Basically, they are just posterior or caudal and inferior to where you would find the nostril. And that's really what sets them apart. Additionally, they have triangular heads. And as you can see here, they have these vertical sort of elliptical pupils. And even more characteristically, as far as just other ways to rapidly identify them, they have these keel dorsal scales, which other non-venomous snakes can have them. But that in combination with undivided subcaudal scales are effectively diagnostic according to the guidelines. And by that, I mean these scales over here past the anal scale over here are singular. As opposed to these sort of interleaved scales over here from this non-venomous snake. Some Google searching showed that this is not always the case, but at least for the majority of the cases, this is true. And of course, rattlesnakes are unique to rattles are unique to rattlesnakes.
If I can chime in on that.
Please.
So if you're close enough to see the elliptical eyes, you're too close. And pit vipers can also dilate their eyes. So you cannot rely on that. The non-venomous snakes can flatten their heads and make it look, so you can't really go by the shape of the head either. And if you're close enough to see the heat sensing pits that are very characteristic, as you said, you're probably too close. If you're looking underneath the snake at those caudal plates, you are not only too close, but you owe it dinner for looking at its rear end. So really you shouldn't rely on those techniques for identification. And if you're dealing ever with an envenomation, I suggest that you specifically do not try to catch it. You do not try to kill it. Just let it be. If you can, take a picture, but otherwise, it doesn't matter really if you, especially in the United States, because if you have an envenomation, even by someone's pet Eastern Diamondback, they're getting a single type of antivenom, and only if they show signs of envenomation.
Yep. Thank you. Yeah, and I do kind of touch, I should have had the prevention section closer to the beginning, but exactly like a lot of what you said were highly emphasized in the guidelines. Thank you for saying that. So kind of breaking it down to North American pit vipers, really the main point is that there are three major, or rather, you have curtilus and cistrus, which are going to be your rattlesnakes, and curtilus are the like far and beyond the majority of North American rattlesnakes, and then you have your Agkistrodon genus, which includes your cottonmouths, also known as water moccasins, and your copperheads. And again, I'm not sure if being able to detect or to tell these apart means you're too close, but one characteristic thing for cottonmouths is that they have this broad sort of dark stripe behind their eyes. And for copperheads, I understand that at least many of them have a thinner one. So that's just something that you can use to identify it. But again, your main sort of goal should not be to identify the snake as much as to just get away from it. So just a quick sort of epidemiology here. Rattlesnakes can be found all over the place. And of course, there's the distinctive rattle. Cottonmouths are more southeastern, and copperheads are a little bit further north of that. Just to have a rough idea. And just because many of us are in Virginia, all three of them are present, in case you were wondering. And something I want to point out really quick that we'll touch on a little bit later is the timber rattlesnake. So these graphs, the black bar is the estimated lethal dose for a human. And then you have your low yield and high yield amount of venom that's injected when you get bit. And as you can see here, like with the copperhead, it's typically lower than the lethal dose. But conversely, with a timber snake, you have an estimated lethal dose that is not very high compared to how much you would be expected to get from a bite. And one of the things I want to touch on later is that timber rattlesnakes, as well as several others, have a type of neurotoxin, which can interfere with care in addition to the other toxins that are typically seen from pit vipers. So pit viper toxins, now that we're on the subject, there are 100 proteins and peptides. Just like many humans or many human diseases, snakes don't read textbooks either, surprisingly. So there's a lot of ontogenetic involvement, and there is some theorization as to whether juvenile snakes have differences in their venom from adults, just based off variations in diet. But really the main point is that juvenile snakes inject significantly less venom than adult, I think from a magnitude of like 3, I believe. So that's just something to keep in mind. The smaller the snake, the less venom typically. And as I was saying, you have the Mojave, timber, and Southern Pacific rattlesnakes that have Mojave neurotoxin or other similar presynaptic neurotoxins, which do affect management slightly. So this is a broad sort of table of those signs and symptoms that you may see in an envenomation. I don't necessarily think it's worth memorizing them one by one. That being said, I'm also a 4th-year medical student. But I do think that the categories are really helpful in organizing how you assess patients and how you order labs. So we'll kind of break them down rather than just running through this table. So first off, our local symptoms. So these are mediated by hemotoxins and or vasculotoxins. They're by far the most common symptom that you might see with an envenomation, as greater than or equal to 90%. And they include erythema, swelling, tearness of the envenomation site, and can progress proximally or distally. And that affects some of the first steps that you take when you deal with these envenomations. And we'll get to that briefly. But first, I also want to touch on some of these systemic symptoms. So these are more suggestive of severe envenomation, moderate or severe envenomation. So I kind of broke them down into categories just so I'm not sitting around memorizing a lot. The first is hematologic. So this can constitute bleeding, angioedema, and they're typically multifactorial, fibrinogen degradation, platelet aggregation, and destruction. And while clinically significant bleeding is uncommon, you still want to examine them pretty closely because it changes how long you might observe them for or how long you might repeat labs, and so on. And it might also hint at some kind of occult bleed. So you're looking for petechiae, ecchymosis, or signs of bruising overall, gingival bleed, epistaxis, retinal hemorrhages, occult bleeds. Like I said, that might manifest as an abnormality on your neuro exam or abdominal issues. So that might prompt further testing. Other things that you might see with systemic symptoms, vomiting. This can also occur from fear and anxiety. I didn't really get as much into how the toxins may cause vomiting. Hypotension from vasodilation, third spacing, and then as we discussed, the neurotoxicity, myotoxicity, and that can manifest as paresthesias, fasciculations, altered mental status, seizures. One big thing that we'll touch on later is also paralysis, which prompts airway management. And as you can see here, this is some gum bleeding after being bit by it's actually, I think in Asia, another type of viper. Okay, so initial management, really the main thing is to get everyone away from the snake. And Dr. Abel was saying you should ideally take a picture, but the recommended distance is at least one snake length away, which is, I would say, a bit intuitive. Honestly, I would probably try to get away further, but that's not evidence-based at all. Also, calm the patient. So understandably, people are going to be upset, and really, like, the literature shows that serious sequelae and fatality are rare and usually preventable as long as you kind of keep your mind focused on the main points, which are to get out of there and to get treatment very quickly. And typical puncture wound management, just for the area of the bite, clean it out, apply sterile dressing, cover it, do your best to prevent any kind of infection or bacterial exposure. And then there are the bits of information that are important to record at the time of the bite. So of course, date and time, as well as the circumference of the bit and appendage. So above and below the bite, because as I mentioned earlier, that local envenomation can spread both proximally and distally. So you want to keep track of how far it is. So mark the leading edge of the erythema as well as how swollen it is. And kind of along those lines with the swelling, you want to in advance cut off any kind of constrictive clothing or jewelry. And like I said, you want to get out of there. You want to get the patient evaluated in a more stable, well-resourced setting. Sorry?
So, yeah, sorry, I'm going to jump in another second there.
Yeah, please.
Because your supervisor said I can. So when you look at the guidelines, they could be a lot, but a lot was for North American cordylid envenomation, which is the pit vipers, is well set. In real practice, and honestly, I personally never bother doing circumferential, and here's why. Circumferential is a bunch of numbers, and it doesn't really help guide what's going on. It's a lot of hoopla, and what's more important is that you measure the leading edge of three things. It's skin changes, so like you said, like the ecchymosis, bruising or swelling, pain, so they can say, hey, it hurts, it's swollen up to my hand, but the pain is going up midway up my arm. But then you also test for tenderness, and those you'll see actually better before even skin changes, and that's more important. And when you're properly elevating the extremity that's bit, and you're treating it, otherwise you're going to see the swelling migrate, and that's okay because you're not concentrating the venom in the distal extremity. So that's going to change your measurements and also kind of make it not as much. But because the venom spreads lymphatically, the distance from the bite mark is a better marker than the circumference. And by properly elevating when you can, granted it's hard to elevate a leg when you're trying to walk them out, then it's going to change the circumferential. So it's, you know, how are you going to measure that when you're out in the wild? It doesn't make a difference. When I'm treating and consulting on snake bites, I don't listen to it. It's just a distance.
Okay, that makes sense. Yeah, that sounds significantly more practical. Yeah, thanks for chipping in. So yeah, I mean, like definitely what makes sense in the wilderness. And then when you evacuate and transport, especially if there are systemic symptoms, I don't think it matters if you are suspecting some kind of envenomation. You just want to get out of there as quickly as possible. One thing that's important is to call the hospital ahead of time, or poison control to at least coordinate, is at least what was stated, to ensure that antivenom is either present at the hospital or that they can transport some over. As we'll find out, antivenom is one of the chief interventions, at least for the more moderate and severe envenomations. And although 25% of these are dry bites, and watching some YouTube videos of other experts, sounds like it might be as high as a third of them are dry bites. You still don't want to hedge any bets on that. That being said, if you're unable to evacuate for whatever reason, you're stuck out there. If the patient is asymptomatic, besides what's there at the bite wound for at least 8 hours, then it's very likely a dry bite. And this also manifests in the evaluation of these patients and teeing them up for disposition if they're in the ER. So 2C recommendations. So these are weaker recommendations that don't have strong evidence. Immobilization of the affected area, splinting may help, but it hasn't been studied as a sole intervention. Another one was to keep the limb at the level of the heart. The rationale being that above the heart can contribute to systemic spread. Presumably what Dr. Abel was alluding to an extent with the lymphatics, and below the heart can contribute to edema and worsen localized action of the venom. Of course, this might be difficult in many situations for the patient to keep their limb exactly at that level, but it's one of those facets of guideline that I guess might be just additional gravy, I guess. And observation on the field is strongly discouraged, only if there's positive identification of the non-venomous snake by an educated caregiver. But as Dr. Abo mentioned earlier, it is difficult to make that sort of conclusion on field, especially if the snake's still alive, and you don't want to take any risks. So now I think one of the significant parts of this presentation is addressing myths, especially with initial management. So the big one is oral mechanical suction. Don't like the evidence on from multiple sources I saw was pretty insignificant. You don't extract very much venom, and if you perform this orally, you risk introducing bacteria, especially human oral cavity bacteria is pretty bad, and you risk creating a superinfection and abscess. Mechanical suction increases local tissue damage and was found to prolong healing by weeks. As far as laceration or bleeding the bite, there's no evidence. Electricity and electrotherapy, the main motivation, it sounds like, to do that is to denature proteins, which was debunked. Cryotherapy and cooling, the rationale was to reduce spread, and it was shown in research to not really do so and to potentially injure the tissue. Tourniqueting may cause ischemia and gangrene. My understanding is that a lot of these toxins damage the tissue. So if you tourniquet and leave it there, in addition to the ischemia, you have further tissue damage, which downstream doesn't really improve things. And pressure bandaging, so the evidence supports use in snake bites containing neurotoxins. However, many, at least in North America, Caroline venom doesn't really contain neurotoxins except for those few species that we discussed earlier. And I think that this is more of a rationale for Elliptidae snakes, which include coral snakes and other snakes that are located in the Eastern Hemisphere. It's my understanding.
Yeah, very right on. You know, the pressure bandaging is really only studied retrospectively in Australia, and those elapids that have barely any cytotoxins or necrotoxins. So really that's the only place where they consider it. I wouldn't even do it for coral bites. I definitely don't do it for even cobras and mambas that are also Lapidae. Yep. And the other thing is, you were saying, you know, when you put a tourniquet on or anything constricting, not only are you just cutting off blood supply, but even if you don't do it tight enough to cut off blood supply, you're concentrating the venom to that area. So you're actually going to cause more damage by keeping that venom concentrated there. So, you know, definitely don't want to do any of the constructing, and no tasing or anything like that, like you said.
For sure. And like as you were saying, that it directly contradicts this whole rationale of below the heart can contribute to edema and worsen localization of the venom. So all the more reason. So we've evacuated the patient from the field to the emergency department. So our initial assessment, of course, ABCs, vitals, monitoring, classic, oral boards. You want to have continuous cardiac monitoring, pulse ox, as well as blood pressure. History of present illness, time of bite, symptoms in detail. And as we discussed earlier, the initial management that you do on the field if it wasn't done already. I'm not sure, in the ER, I'm assuming it doesn't really help to measure the circumference either. But that's basically it for the initial assessment. And then kind of the diagnostics. This is where it gets a little bit more involved, but I think it kind of helps to sort through those symptoms. So first, place an IV in the unaffected extremity, which is reasonable to do. And as far as the initial tests, I kind of sorted out into a few categories, again, to just make it easier to remember. So first is coagulopathy, anemia, thrombocytopenia. So you get a CBC with platelets, PT-INR, PTT, fibrinogen, the measured one and not the calculated, as well as a D-dimer. And as we discussed earlier, also you want to do serial neuro exams. This is in addition to keeping your eyes peeled for any paralysis associated with the neurotoxins. It's also to keep vigilant for hemorrhagic CVA, as well as abdominal exams, at least one good one to keep vigilant for intra-abdominal bleeding. As far as electrolyte abnormalities go and concern for rhabdo, which is a pretty big concern for these patients, BMP to assess for kidney function, urinalysis, CK. If proteinuria is present, test for myoglobinuria and microhematuria. And if muscle swelling is present, myoglobinuria, do serial CKs to ensure that the patient's trending downwards, fluids is needed. And then for hepatic function, LFTs, it's reasonable. And then for critically ill patients that have chest pain or shortness of breath, your typical sort of cardiac workup, EKG, chest x-ray, troponin. It was interesting. I don't know how well vetted the study was. I think there were 30 some patients in India that were studied, and many of them had EKG changes, especially QTc prolongation. So I want to throw that up there as extra information. This is kind of a summary of everything. Again, I just think it's easier to sort out, but I wanted to leave this in here in case you want to look through it later. So diagnostic and assessment as far as for kind of the different levels of envenomation. So if it's dry or no bite, you observe for 8 hours. Of course, you get initial lab studies, but if there's no progression, if it just seems like that local tissue damage, just keep them around and make sure that their vitals are normal at the time of discharge. They don't need anti-venom. Minor symptoms are more sort of just, it's limited to local systems. So you want to observe for 12 to 24 hours, do initial lab studies and repeat every 4 to 6 hours. So the initial lab studies are it's kind of the entire battery that I described earlier. And the repeat labs are going to be more the hematologic sort of monitoring labs. So platelets, PT-INR, fibrinogen. The INR is kind of the most helpful. Fibrinogen's really specific, and the dimer is kind of more on the sensitive side, which I think is why the dimer was excluded. And you only really need anti-venom if it's a high risk area, like the hand or the face, where you're worried about function. And then for more moderate and severe patients, so systemic symptoms, progression of local envenomation and organ damage, that's kind of where you want to admit them, get your initial labs, and then repeat them at the time of, or 1 hour after anti-venom administration, and then every 4 to 6 hours until they stabilize fully and you get normal labs and normal vitals. that's kind of a quick overview. And that basically summarizes the disposition. There really isn't too much here in addition to what I said, except for if they have a moderate and severe envenomation, you want to follow up in 2 to 3 and 5 to 7 days post antivenom administration, because there's still this risk of coagulopathy after discharge. So you want to repeat your CBC, PTINR, and fibrinogen, as we discussed, and kind of along those lines, preventatively, no contact sports, dental extractions, things that can make you bleed, really. And another interesting picture. So this patient was bitten on the hand, I think it was the other hand, and had widespread bruising. So it can, like even a small bite distally can cause these systemic symptoms. So a little bit on the interventions. So the antivenom that is at least used in modern medicine, especially in North America at least, is CroFab, which stands for Crotility Polyvalent Immune Fragment Antigen Binding Proteins. Basically, roughly speaking, they're like monoclonal antibodies that bind the toxin so it can be expelled, or to at least neutralize it rather. I'm not sure about expulsion. And basically it's ovine derived, so derived from sheep. I think before the turn of the millennium, it was equine derived, but that wasn't as efficacious. And basically you have 4 groups of sheep, and they are longitudinally exposed to venom from eastern and western diamondback rattlesnakes, the Mojave rattlesnake, which again has a neurotoxin, as well as the cottonmouth. And all these antibodies are digested using papaya extract, papain, and then pulled all together into CroFab. So you can use CroFab for the vast majority of envenomations in the United States, except for the Ipidae, like the coral snake. So antivenom indications, as was alluded to earlier, if it's a non-pit viper bite, if it's a dry bite or a minor envenomation, it's not necessary unless it's a minor envenomation in a high risk site like the hands, joint, or face. However, if you have progressive, moderate, or severe envenomation, that's where you want to administer antivenom. And whenever you do that, you want to contact a medical toxinologist or poison control. And these are kind of the definitions for those 3 categories. Really for progression greater than 2 centimeters of erythema expansion or systemic symptoms or lab abnormalities. Moderate and severe kind of are what we described earlier. You have these systemic symptoms, moderate being non-life-threatening, severe being life-threatening. And then severe also has abnormal coagulation tested with bleeding. So just an example of this one probably constitutes a patient that, I don't know if this would count as minor really, but high risk site. So antivenom administration can get to be a little bit involved, at least from what I was reading. So first thing you got to do is you have to reconstitute it. Basically, the instruction is the antivenom comes as a powder, and you basically reconstitute it in, it's recommended 18 mils of saline, but really it sounds like anecdotally 25 mils allows for improved dissolution time. And then you basically rotate the vial several times until everything is mixed properly. And then you further dilute it in 250 mils for an infusion. And basically your initial dose is going to be 4 to 6 vials. And you want to administer of this entire reconstituted antivenom 25 mils over 10 minutes initially to observe for any reaction. And then if there's no reaction, administer the rest over the course of an hour and repeat until you have initial control, which is basically no progression, improved vitals, improved systemic symptoms. Upon achieving control, you want to get repeat labs and then dose 2 vials every 6 hours times 3. One thing to note is that this is not weight-based. The only it's really to neutralize any venom that's floating in the body. So the snake doesn't inject venom based on the patient's weight, as far as anyone knows. So it's the same, it's standard for all patients. The only sort of exception is if you have an infant less than 10 kilograms, you want to be careful to not cause edema by fluid overloading them. So really in those patients, you want to approximate a 20 mils per kg bolus. That's really the only exception I could find. Sometimes it takes as high as 18 vials to achieve that initial control. So it's not always just the 4 to 6 vials, but 88% of patients do achieve it, which is pretty good.
Yeah, I want to reiterate exactly what you said because these couple of points are probably the most misunderstood. And if you, this is part of the problem with even the article, the case that was present, that in the reading where they went wrong and it wasn't treated appropriately. Um, if you go back one slide,
Yep.
I just want to completely reiterate. So pharmacies get this wrong all the time. We used to like put it in the vials and we'd all roll it together like this and warm it and wait, but you put them in fact, you get this handy dandy, very expensive medical device called a Ziploc bag. And you put the vials in it, and with all 6 vials or whatever together, you just flip it up and down twice a second and it reconstitutes in 7 minutes. So when the pharmacy is taking 30 minutes to 90 minutes to reconstitute it, it's because they didn't read the new labels that came out 4 years ago and they're putting it on the roller plate. This slide I try to get to all the pharmacists because they don't get it how easy it is and it's taking too long. And if you're actually physically doing it, it can be a little hard to get anything more than 15 cc's in there. So you might have to like suck out a little bit more of the air and then to put that in, but that high pressure really helps make it reconstitute. And I just take this saline out of the 250 cc bag that we're just going to infuse into them anyway. So I'm really glad you have this on there because it's always mistaken. And then if you go to the next slide again,
Sure.
this is the other big part where PAs, physicians get it wrong all the time. It's like pissing on a fire, unfortunately. So you give the initial dose of 4 to 6 vials. It might be 12 vials if they're unstable or severe. And you give that over an hour. And after an hour, you need to reassess. You keep doing that every hour until you get initial control. And I'm so happy to hear you say those words. That initial control, you have to have 3 things. Number 1, either regression or no longer having progression of local signs and symptoms. So that can be skin changes, that can be edema, that can be ecchymosis, that can be swelling. Okay. If you have any abnormal labs, they have to be trending towards normal. So you would get them again. And then any systemic signs like repetitive vomiting or retching or hypotension, altered mental status, systemic signs, that has to have ceased. When you have all 3 of those, then you can get out of that little revolving door where it has about initial control, and then you can go on. And there were a number of studies that showed by doing this simple scheduled maintenance dosing helps lock it in, just like how we're getting the second dose of the COVID vaccine. It kind of locks it in instead of just piecemealing it here and there. But you may have to. Most of my bites that I treat down here, 16 to 18 vials total they're going to need for their entire treatment. But there are times I've had where 40 vials before they got initial control. I know, Drew, nice face, right? It's true. 44 vials. I've had one guy that had 88 vials because we were playing such severe catch up, which I can tell you about those cases sometime. But it's really important to recognize, as you were saying, that initial control, it's only the initial dose and then you lock it in. So you're doing that ongoing assessment. Personally, I don't let them out of my ER until I have initial control because I don't trust the hospital and pharmacy and ICU to continue because a lot of times they even get transferred and they're like, well, they already got the dose. Well, it's not weight-based dose. And you also can't look at the snake to see if it has a meter to see how much was injected. So you're going by clinical signs exactly as you said. So thank you for saying that.
Thank you. It's really helpful to have the important parts pointed out because it's difficult to discern just reading through the paper. So as far as how to administer the antivenom, the first thing you want to think about are contraindications, of which there are no absolute contraindications. Certainly with envenomations that are that severe that they demand antivenom, the benefits outweigh the risk. Really, the one thing, like I mentioned earlier, is that it's reconstituted in papain, which is derived from papaya. That basically helps to cleave off the FAB fragments that are used in the antivenom. And there's a 1C recommendation. Hypersensitivities occur in 8 to 13% of cases. So you can dilute. So instead of the 250 mils, you can dilute into 1 liter of saline and slow the administration. There was some attempt at pre-treating with promethazine, hydrocortisone, and prednisone. Those were found to be ineffective according to the guidelines. And then if you give antivenom, you admit for observation, repeat labs, redosing, as we discussed. And if the patient deteriorates, of course, it's no longer under control. So you give more antivenom and you call a toxinologist and or poison control. So that's it for the antivenom, which is the mainstay of the treatment. Also, a quick discussion of the wound care. So initially, local care, antibiotics, the rate of skin infection due to pit viper bites are really rare. So prophylactic antibiotics make a minimal difference. Really, I think it drops from 3 to 0 with prophylactic antibiotics, but even then, really the guideline is to only prescribe antibiotics if there are obvious signs of infection, such as purulence. If you have a significant open wound, this is just like standard wound care, as my understanding, moist dressings change twice a day. If you have large debrided wounds, consider negative pressure dressing. Functionality, if functionality is at risk, early PTOT is helpful. For pain controls, so I thought this was interesting. Opioids are preferred, and 2 really good rationales that were given in the guidelines. Firstly, NSAIDs and aspirin can worsen the coagulopathy as blood thinners, and furthermore can contribute to pre-renal acute kidney injury in the consequence of rhabdomyolysis, just based by the disinhibition of the prostaglandin effects on the arterioles in the kidney. And lastly, remember to update tetanus if needed. There's no evidence suggesting that historically there was a reason to update the tetanus or any tetanus infections as a consequence, but still does not seem like a bad idea. And that was what was written in the guidelines.
About the pain control, we also the Snakebite Foundation at Venom Week, we just presented about the use of ketamine for pain control, and that's what we use mostly at our snakebite clinic in Guinea in West Africa. And then anti-venom, when you initially, you might need the opioids or ketamine, and once you get the bite under control, I'm quickly able to switch them to just Tylenol, which is great. But ketamine is another option for that initial pain control, along with opioids.
Gotcha. Yeah, and it seems like a lot of symptoms get mitigated just by administration of the antivenom. Is that correct?
Yeah, absolutely.
Cool. So let's say the wound is pretty bad, then you have to look into, or one might consider debridement. So historically, surgical debridement was routine. However, evidence shows higher complication rates secondary to the debridement, as well as on histology, they actually found that there was a mixture of live muscle fibers as well as necrotic fibers, which suggests that the tissue was actually salvageable the whole time, at least in many cases. So the current standards are debridement of necrotic tissue and hemorrhagic blisters only if they are present 3 to 5 days after the injury, after all is said and done, after you've administered the antivenom. But really, the debrident's also indicated with antibiotics, potentially, if secondary infection develops. However, most of the time, the antivenom kind of takes care of the process, the wound that seems like it may need to be debrided. One thing that I thought was interesting that was mentioned in the guidelines is that copperhead bite wounds rarely require debridement. Maybe a way to remember that is that the lethal dose for humans compared to the amount that's injected, is typically lower. As far as this picture, this is actually from South America, I believe. They think that it might have been a viper, but they weren't fully sure. But this patient received local treatment and didn't have any sort of allopathic care until it was way, way, way too late. So it's kind of thought it was interesting. Some patients do need to be debrided, I guess. So as far as compartment syndrome goes, I've kind of heard this just as a layperson when it comes to this topic. True compartment syndrome in the context of snake bites is very rare, and there's a good deal of information to show that, or evidence to show this. The swelling is usually subcutaneous rather than subfascial, which is where compartment syndrome would be. And if venom is deposited in the muscle compartment, antivenom usually treats it, kind of as we alluded to earlier, with antivenom solving a lot of problems. There were 2 review studies that were mentioned specifically in the guidelines, where they looked at the instances where fasciotomy was required in a snake bite, and one had 0 for 500 cases, and the other review had only 2 out of over 1,000 cases. If there is concern for compartment syndrome, at least what I got from the guidelines is that you want to do serial examinations for 36 hours. 36 hours is usually where the swelling peaks. And really, if there are concerning symptoms, that's when you measure the direct pressure, like the pallor, numb paresthesias, et cetera, the classic P's for compartment syndrome. By definition, at least provisional definition, greater than 35 to 40 megs or millimeters of mercury suggests compartment syndrome. So consult surgery, redose the antivenom. Usually if you give aggressive antivenom, it sounds like, again, following the pattern, that suffices to treat it. In rare instances where it doesn't work, that's when you might have to look into a fasciotomy. Similarly, digital dermatotomy, dermotomy rather, over the back of the hand, may really be required as well. Only, and really to assess for this, you do serial neuromotor exams and you check for Doppler readings. And if they're concerning and not responding to antivenom, that's when you look into that procedure.
Yeah, the I'll say very strongly that fasciotomy, snake bites are a traumatic disease, but not a surgical disease. The outcomes are, it's well worded by Nick Brandehoff, who's another snake bite expert. He's a toxicologist out in Denver. But the outcomes from fasciotomies is a whole lot worse because the tissue and everything that's going on. And I actually had a case. Part of the problem is a lot of people are so quick because they're like, well, we need surgical consult, and they kind of look at it and they kind of poke. And the P's of compartment syndrome is pain, 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 paresthesia, pulselessness, right? So
Yeah.
It's already painful from the venom itself. When I was at University of Florida, I had pain written all over the place. But even if it's measured compartment, if you treat it appropriately, it's not going to get to that, especially if you elevate it appropriately. I actually had a case of, and I'll share with you the pictures. I'm about to submit this, but 7-year-old girl that was right hand dominant, bit on the hand by a pygmy rattlesnake, and they gave the antivenom inappropriately. They gave her the right dose, but they gave it over 6 hours instead of 1 hour. And then they never did the maintenance dosing. They never had control. They never elevated it except for on a little pillow, like she sprained her ankle. The next day they had the surgeon look at her because she was still in a lot of pain. They did she was bit on Friday night. They did a fasciotomy Saturday, discharged her Sunday. Monday morning, it's bulging at the sutures. The pain is continuing to progress up the arm. It's oozing blood from the surgical sites on her dominant hand. The grandmother happened to see me on the news on something else, and they called me. They brought her to me from across Florida, and I gave her the proper dose of antivenom. And within 30 minutes, all that pain and oozing stopped, and she was able to play with her Nintendo Switch. And so they never needed to do the fasciotomy in the first place, and they could have caused more damage. So I actually had to get her physical rehab afterwards just to deal with the contractures and things from the fasciotomy itself. So, true compartment syndrome, absolutely very rare, especially if you treat it appropriately. And honestly, the fasciotomy is not going to be needed. Maybe debridement, as you mentioned, you consider it after the bite's finished evolving, 3 to 5 days. But you're not going to need, it's not going to do much for this. And it's going to cause more tissue damage. So it's really hard to clean up after they've done this. So remember, it's a traumatic disease, not a surgical disease.
Gotcha.
Dr.
Yeah, no,
correct me if I'm wrong. From what I've seen, the fangs actually very, very rarely truly penetrate the fascial layer. So if the fangs don't penetrate deeper than the fascial plane, then truly you can't actually have
So that's actually a really good question. In case you didn't hear, a lot of times the fangs don't penetrate the fascial layer, so you couldn't really. Yes and no. Yes, it's true that most of the time it doesn't get past the fascial layer, but sometimes it still does. But even as the venom is spreading up lymphatically, it can spread in, even with a nick in the fascia, can therefore lead underneath it. Um, so that's like a theoretical talk and kind of depends. I have a lot of, Eastern diamondback is the largest venomous snake in North America, and it's the 21st largest in the world. And we have a lot of those bites down here, and those are some pretty big fangs. And I do see them often get past the fascial plane. It's kind of a hit or miss whether doing it. And looking at the statistics, we don't measure the depth of where it's gone. So that's, we're not cutting off someone's arm and being like, oh yeah, hey, it broke the fascial plane. So it's kind of tough to decide on that.
Interesting. Okay, just a couple slides left, so I'll just breeze through these so that I'm not stealing everyone else's thunder. So unique patient populations, pregnancy, really the big thing that was noted in the guidelines is that it doesn't necessarily affect the pregnant female as much, or it doesn't affect mom as much as the concern for fetal death, and that occurs in 20% of documented envenomations. One that seems relatively intuitive is placental abruption, just kind of in consideration of all of these potential coagulopathies. Otherwise, you just want to coordinate with OB-GYN. For pediatrics, it's basically what we harped on earlier, which is you administer the same dose of antivenom as an adult for neonates less than 10 kgs. That's where you want to look out for the risk of edema just from fluid overload. And this is the last slide. So basically critically ill patients, things to consider. Really most of them, it sounds like either give a lot of antivenom or give the kind of care that you otherwise would. So for example, with shock, you want to give crystalloids with antivenom, which is still the mainstay, and then presters if they're not responding. For the focal neurodeficits that we discussed with neurotoxins such as Mojave, ptosis is one of the earliest signs. I actually meant to have a picture of it, but you can Google it, and there are some pretty good examples. Dr. Abel is demonstrating for us right now. I think that's going to be seared in my memory. So that's good. So antivenom doesn't work quite so well for that. So with these patients with paralytic features, you want to evaluate them quickly and consider intubation/ventilation relatively early. On a similar sort of vein, you have respiratory compromise seen in 8% of patients, 4% requiring mechanical ventilation. Kidney injury from rhabdo, standard treatment, aggressive fluids, urine alkalinization, dialysis if needed. For hemorrhage, anemia, antivenom is again the mainstay. If you get rid of the toxin, presumably that deals with the source of the issue. Consider blood products only if refractory. You don't need to go transfusing immediately unless the patients really are at that refractory point. Other complications mostly seem to deal with coagulopathies. These seem to be more case reportable than common, but there were some instances of multiple pulmonary emboli, refractory thrombocytopenia, catastrophic ischemic strokes after antivenom administration. They seem to be incredibly rare again. One sort of trend that was recognized in research is that 0.5% of those treated with the ovine antivenom, which is the current Crofab, had medically significant sequelae, including instances requiring blood transfusions. But again, I think that's part of repeating the labs at the 2 to 3 and 5 to 7 day marks after administration of the antivenom. Again, the PT-INR, fibrinogen, and the CBC with platelets. So that's it. I understand. Oh, no, prevention. So Dr. Abel already touched on this earlier, but the main thing is do not handle. It sounds like the majority of injuries are from interaction with snakes, and coincidentally, they are young men, 25 to mid 30s in age, that kind of are like this guy here. He was this fellow in Arizona that was wrestling with a snake and got bit in the face as a consequence. This additionally includes dead snakes, which I could see someone that's just trying to be helpful in the situation that wants to take a look at the snake to identify it. Apparently, some of them can have a bite reflex that may still be intact. So that is also worth considering. Just don't go near the snake, it sounds like, and don't try to kill it. Clothing, denim may decrease envenomation by as high as 2/3, but really, I think avoidance is a better strategy. Be aware of where the snakes may be found. They're ambush predators. They kind of just find a nook or cranny and stay still and wait for prey to come up. So typically underground shelter, they avoid temperature extremes because they're poikilothermic. In areas of extreme cold, they may be migrating between sites. So that's something else to keep in mind. And kind of along those lines, one more thing I want to mention is the whole notion of defensive versus predatory bites. It sounds like the vast majority of times with humans, unless it's a snake in captivity that's used to humans, it's going to be a defensive bite. And typically defensive envenomations have a greater amount of venom that's injected. Not that that makes any difference to treatment, because again, it's purely based off the patient's presentation when they show up at the hospital. So that's basically it. I realize I took forever. I apologize for that. But I really do appreciate Dr. Ivo pitching in. I think that that really helped to focus a lot of this information that's here to what's relevant. But I'll be glad to take any questions.
I'll just add that, think about your pets too, because dogs are stupid and curious, and they like to put their noses underneath rocks and things. And I live in Colorado, and I have to be careful with my dog if I have him off leash, like where he's going. So I always have a shock collar on him to like pull him back because we've had dogs die from being bit on the snout.
That's a really good point. Because of the urban search and rescue, I do time at the University of Florida's vet hospital to keep my canine skills up. And we carry antivenom special for the dogs. The CroFab does work for the dogs. There is a canine FDA approved antivenom that only costs $250 as opposed to $3,400. Usually only need usually a vial or two, but they present a little bit differently. But they'll be bleeding at the site and pretty painful for the pit vipers. But what I do for my dog, Otis, oh, he was just in here. Anyway, I actually trained him in snake aversion. And if any of you want, I will, basically I had a handkerchief that I put in a snake pen for a couple weeks, and I'll mail one to you if you want. But I would put it in different places, and whenever Otis, my
mine
dog,
is really dumb.
Whenever Otis would go near it, I would make a loud noise. I'd freak him out. And so now when he senses or smells a snake anywhere nearby, he won't go near it. He'll just sit and bark and stay away from it.
Nice.
And we've been hiking in the Everglades, nowhere near crocodiles and alligators, but he's been pretty good with sensing snakes so that he doesn't get bit. So prevention is great.
Yeah, that's nuts. Definitely in my research for this, there were a lot of dogs when I was like trying to pick up images to make this PowerPoint a little bit less dry. I just felt like it would not be politically correct to include those animals. They were really rough looking. So it certainly seems like a problem.
Poor things. They could be really scary looking, but they usually do pretty well. And if you ever have a pet that's bit and then the vet just wants to give Benadryl, you tell them to take a hike and you call me. Well, because Benadryl is not the treatment for dogs bit by snakes.
Cool. Yeah, we should probably throw your number under the poison control one over here. All right.
I'm not sure. I have a short case that I saw that I said I could share at some point, but whenever you guys want to go to the next article or whatever, we can totally do that. But
Feel free. I made it so anybody can share screens.
Oh, cool. Yeah, I can do. It's like five. I think I did like 5 slides or something like that. But so I'm just introduce myself really quickly. So I'm Linda Sanders, and I did a wilderness medicine fellowship in Georgia, and I live in Colorado, and I work in community hospitals in rural Colorado. So mainly in Canyon City, Colorado right now, which is like a big rock climbing, mountain biking area, kayaking, things of that nature. So I'll share my PowerPoint. It actually was originally supposed to be for a lecture that I was giving to my alma mater. Let me know if you guys can see this. Can you see that?
Yep.
So I work in an area where people like ice climb, rock climb, mountain bike, get into a lot of trouble. So this is the case. So I was working at my facility in rural Colorado, and I got a call from EMS that they were en route with a 67-year-old woman bitten by a snake in her yard. Her husband saw the snake and confirmed that he thought it was a rattlesnake. We got a report that she was tachycardic and diaphoretic. The husband killed the snake, and then again confirmed it was a rattlesnake from his report. He did seem confident. So my question to y'all is, how can you prepare for the arrival of this patient with this call out? What are your first things?
Call pharmacy and see how much anti-venom you have hanging around.
Yeah, I completely agree. I think calling pharmacy and finding out what you have and asking them to prepare it beforehand is the way to go. So I spilled my coffee and my desk is always a mess and stuff. But it does depend on what kind of anti-venom you have. So actually there's a new anti-venom out called Anavip, which reconstitutes faster. And our hospital just switched over to it. We, at that time, this was 2 summers ago, we're still using Crofab. So, but now it would be like a different process because we use Anavip. So Crofabs, again, takes like 30 minutes or so to get ready from pharmacy. So I kind of told them to get started on that just based on what report we were getting. Like she was tachycardic and diaphoretic. It didn't sound good. Anavip takes just a few seconds to reconstitute. Now the data for it, I mean, I think there's only like one randomized control trial of Anavip. It's similar. It comes from a horse serum instead of a sheep, but it works similarly. It uses less vials. It's actually cheaper, which I'm sure is the reason my hospital did it. Because let's be honest, they don't want to spend any money. You can't even get them to get a transvenous pacer. So yeah, but you should probably research what you have. Like if you're in an area where this is a possibility, it's good to know ahead of time. But my first call was to the pharmacy. I agree with that. And then letting my team know to kind of prepare the resuscitation room, right? So she arrives and her blood pressure was 80/60. Her heart rate was in the 120s. She was diaphoretic, pale, and actively vomiting. There was a bite wound to her right hand with swelling that was going up from her hand to like the middle of her forearm. Her airways pain, she's talking. So that's your patient. And they told me Crofab was probably going to take about 30 minutes still, in spite of me calling ahead of time for them to do so. So in the meantime, we didn't have the Crofab ready, basically. So what are your options here?
Was a huge fan of Epi. I mean, she's got 2 systems involved of.
Yeah.
Looks like
anaphylaxis. Great.
Epi,
so
Epi.
Right. So yeah, we had 2 large bore IVs. We gave her a fluibles and we started Epi. Yeah. Obtained some labs. Epi's going while we're waiting on the Crofab. We already kind of went over, I guess that was a great presentation of what labs you might order, because that does help, guide your management of these cases. So coag, CBC, CK, urine, and CMP. And we know about what enzymes these pit vipers tend to use to kind of digest our tissues. So resulting in capillary damage, liver and renal dysfunction, and coagulopathies. So we know what we're looking for. And then the indications were kind of covered already too. So, the envenomation that's moderate to severe, obviously diaphoretic, tachycardic, and hypotensive, she's going to qualify for anti-venom. But there are also, less severe cases where you could consider like based on labs to make that decision. So how do you dose the anti-venom? Actually depends on which one you have now, because Crofab has a pretty short half-life. And so you do have to redose very frequently. We talked about doing that like every hour, depending on how sick that patient is, versus Anavip, which has a much longer half-life and less redosing. So usually it's 10 vials over 10 minutes, and you can repeat it if they're not improving, and then it gets far more spaced out than Crofab. And it's quite a bit cheaper. It's like, I was looking like $15,000 cheaper than Crofab. So I foresee a lot of institutions going in that direction if the data continues to pan out that it's good, which so far the data looks pretty good for it. So
For rattlesnakes only. Yeah.
yeah, for rattlesnakes. So, potential, complications, serum sickness, acute hypersensitivity reactions are definitely something to consider, but, it is the treatment, so we're going to do it anyway. So at this point, she was actually doing a bit better, and Life Flight had arrived, and the patient was getting packaged. And then she's like, oh, my throat's closing up. Great. Like literally Life Flight's like ready to take her. And she's like, I think my throat's closing up. Not awesome. So, what are you going to do? You're going to let Life Flight take her when she's saying that? So what do you think?
We got video laryngoscopy, my favorite thing next to sliced bread, or we're gonna get crikey.
Yeah, definitely an option. For our hospital is really small, and I don't have regular access. I mean, they have to like get it from the operating room, and I think one person has found it like once, so it was not going to happen quickly. I talked to her husband, and I was like, hey, I think we have to intubate your wife before she gets on this flight. And of course he says to me, oh, well, she's a difficult airway. And I was like, seriously, what do you mean by that? Like, how do you know she's a difficult airway? Well, once in surgery, someone told me. I was like, oh God, great. So, you have your glide scope or whatever, you have your CMAC, we had a glide scope, and had an LMA there and a bougie, and you could consider an awake intubation with like ketamine. I have not had to crike anyone by doing those things. So I personally think if you have all the right stuff, you can generally avoid criking people. So she rapidly desatted as I was doing this. And we ended up getting the tube. We put in an LMA briefly just to bag her up, and then we re-intubated her with a bougie, and it worked out. I guess this brings up the point that was brought up during the lecture, which is if this was anaphylaxis versus was this due to the actual bite. I guess I don't know. Like, we had already started Crofab, like maybe it was from Crofab, or maybe this was just progression of her reaction to the bite. And then do you stop the infusion, which, I think was adequately covered. Like, no, I mean, you can briefly stop it, but then you're going to restart it after dilution at a slower rate. So, and then you guys really well covered, special considerations with compartment syndrome and pregnancy and so forth, and the do nots of snake bites. And that is really what I had. But it was a scary case. I actually saw the patient again, like a year later for another completely unrelated visit. And sorry, my dog's barking. Yeah, so, and she was doing great. So thankfully. But any questions about that? It was scary. It was my first actual snake envenomation here, living in Colorado or elsewhere, because previously I lived in the city, like in Seattle or Philly, so I wasn't really seeing this. But it was scary. She did really well. I underestimated the amount of time pharmacy was going to take with the anti-venom. And that was my like big takeaway from this, was like, okay, like as soon as we hear about it, we have to get started. So.
I do have a question. So when she said her throat was closing up, do you think it was that she was having an anaphylactic reaction to the antivenom?
I mean, I think it's possible. I mean, it had been going for almost an hour, so certainly long enough for her to have developed a reaction. I mean, it's also certainly possible that it was from the envenomation, but she didn't come in saying that, and she had no like mouth swelling on her initial exam. So I kind of think it was more likely from the antivenom.
There's a third possibility that it could be. And that's exactly, you need to question, you need to look and kind of consider. The third possibility is that it's just an anaphylactoid reaction, which is very similar. Crofab's safety profile, pretty good at the most, some hives, and there's some people that get a little itchy or anaphylactoid, and they start thinking, that's why I wrote in the chat of my capnography, like they feel like their throat's doing something or whatever. Do your thorough assessment as the clinicians that you are or that you're training to be. Capnography, I'd see if there's any new bronchoconstriction. And then we initially, if it's really severe, then I would stop it, do what you need to do. Otherwise, I just do epi and I slow down. And a lot of times just slowing it down is how you treat the anaphylactoid reaction, and it kind of goes away. So you need to kind of see, because some people think as soon as they start getting itchy, they're like, oh no, what about up here? We'll see if it's really constricting. Is their voice changing? Is there shark fitting on the capnography? Are they have any GI symptoms like the cramping? So histologically, so kind of try to discern. It could be a reaction to the venom, could be to the antivenom, could be to just anaphylactoid.
Is there anything wrong in treating the anaphylaxis-like conditions at the same time you're dealing with the crofab? Just, I mean, if you're going to have two IVs.
That's actually exactly what I would do. I don't, if it's, for me, my recommendation is if it's really severe, go ahead and pause it so you can do whatever. But then you're restarting it and I'm treating it at the same time. Otherwise, well, it's the real treatment for anaphylaxis anyway. IM epi, and then you have the IV ready to do form or a drip. And I can show you a case where I had someone that was on pressors and epi and stuff, but yeah, no, you can treat them both at the same time, or do it, as said, you stop it, you do what you need to, and then you manage and continue up the antivenom again.
And is your shop or using Anavip now, or do you know? Because I just kind of got an email this summer that we're switching over, but I feel like my hospital just tries to do the cheapest thing.
So their Anavip was approved for rattlesnakes only. It is for steroids. They price it in a way, and I put some of the stats from, the 10 vials are only 65% are getting control from the initial. Then another 25% are getting it at 20 vials control. There are ones that are doing it over. Down here, we're not. I have all of them. Well, I have every antivenom that's worthwhile having. I have 1,500 vials in my fridge, or fridges. But we're not converting over because we don't have a lot of. Really, it's just out west where they're converting completely over to Anavip because they only have rattlesnakes, so they're approved. So you're not seeing that. There are a couple places where they pharmacy switched to Anavip, and then they had they had either moccasin bite or they had reactions to it. So then they're transferring the patient, or my venom team's showing up with crofab because they only had Anavip, and then they're switching and get right back. So it's kind of a mix. So yeah.
Sweet.
So this kind of lends itself towards changing the article sequence up. Mariana, do you feel like you could hang on while Drew discusses his case first? Is that we were kind of discussed relatively important part of it?
Can you guys
No
hear
idea
me?
what it is.
Yeah.
All right. Ready for this? Let's go with this one. Just pick them like if you want to agree with me. All right. So we've got a case report here of angioedema and dual nurse flight crew cricothyrotomy after envenomation by a severed rattlesnake head. Some things we've discussed several times so far. The severed rattlesnake head being very capable of still biting well after it's severed. And as we were talking about earlier with the younger snakes, while proportionally having less venom, having less judgment on how much they use, similarly, a severed snake head will have both sides of the worst side of that coin of no control and all the venom of a fully grown snake. So this chap, this is the same information we've gone over in the previous things, highlighting for ease of finding things. Catch for it, where they're calling it treatment of anaphylaxis. So it's a 57-year-old man, and again, the 6 T's of getting bit by a snake appear to apply here. He has decapitated a snake, and he's promptly bitten on the base of his thumb. He immediately apparently goes into respiratory distress, and they call 911. As talked about, they get there. He is experiencing impressive edema, and he's given 2 doses of 0.5 milligram IM-epi, which we've talked about, which is awesome. So now that they're 45 minutes out, they've realized that he needs, well, they've called air evacuation in 45 minutes. That used to be my corner of the county. We were down the Uari, and we had more rattlesnakes than people. So this part here caught my attention greatly. His tongue was protruding. I've seen some anaphylaxis, but I've yet to see an anaphylaxis with the tongue protruding, but I have seen some things that did make a tongue protrude, and this really caught my attention. I just highlighted some vitals here just so we can keep track of this because it's kind of scattered. And entitled capnography because it just makes me happy. So we have the flight nurses have arrived. We have middle-aged man, oral edema. This goes into how they're correctly positioning him for, they're gonna try and do a drug-assisted intubation or RSI. Drugs they used, same things everywhere. They used a video laryngoscope and a bougie, no effect. They went to a surgical crike. So after the crike, this guy, waveform capnography, great. So we moved on to the transport. We've gone to more saline, 125 milligrams solumedrol, more albuterol, a norepi drip, but we don't have any vitals before it, which is trying to figure out why are we doing a norepi drip. We don't have any commented vitals, but they say his blood pressure is rising now. And a very neat trick and pre-hospital notification is awesome. They've called ahead and asked them to prepare several vials of Crofab. Saying once he arrives, here's his vitals once he arrives at the hospital. Continued profuse bleeding from the cricothyrotomy incision site, IV site, puncture wounds, and more edema. As I am but a youngling, I will need a little help with the labs here to interpret because I'm young. I'm not this versed yet. So
They're not normal.
yeah, they're not normal. Oh, no, I know that. I'm just trying to figure out on what parameter bad are we. I don't know what a D-dimer means, but so our coagulation cascade is just wrecked.
Did anyone say what that sort of profile looks like? What the clinical condition that seems to be suggesting?
Sounds like DIC.
Yeah, it sure does, doesn't it?
Which is a nasty side effect of, as we were discussing with the venoms earlier, it's nature can't read books, and so rattlesnakes don't know what the recipe for their venom should be. We have a good guess, but there can be some variation. And this guy, they're guesstimating it was a Oregon rattlesnake. So we discussed, here's it, more epi for persistent hypotension that we haven't discussed. We have a pressure here, but they don't discuss anymore. And here's where we start. I put CroFab in purples. We have 6 vials of CroFab and 2 units of fresh frozen plasma and red blood cells. Well, I did notice is up here in the values, there's no hemoglobin or hematocrit, so I'm not sure why we have packed red blood cells. And even after all this epi, we have no change in facial, airway, or extremity edema. Yeah. So, and inconveniently, at the end of this page, we have so you're thinking because of the snake was, yeah, I don't know. I think because of the severed head, that he's gotten every ounce of venom this snake could have held. There's no sign of a snake. They have no idea what size it is. They're assuming due to the region what it was. He got an initial 6 and now he's got 12 vials of ProFab, which I don't believe were in any of the guidelines or recipes, but I'm not there. And then we're talking about more coagulopathy. But how are we going to fix a coagulopathy? We can give him all the ProFab in the world, but if his coagulation factors are used, he's not going to make any more soon. And then another 2 vial bolus, and then another constant infusion of 1 vial over 4 hours. And then another 2 vial bolus. And then another 2 vial bolus. And then
Compare that timeline. Just think about that a moment. That timeline of what they just did versus what was just presented in the timeline of the approved how to do it. Right, of the 4 to 12 hourly until you get control, and then the maintenance dosing every 6 hours, as opposed to 2 vials after 4 days, a vial every over 4 hours. That's a lot different.
Yeah, I did a little looking around on various things, and I have no idea where they got this recipe from. But hey, he walked out. Evidently, he literally walked out against medical advice with day 6. But he did come back for repeat testing and severe coagulopathies because every bit of his coagulation, all of his factors are gone. And while they threw some red blood cells at him, I'm sure because he was bleeding, we didn't replace any platelets. There's no fresh frozen plasma. So the thing that was getting me on this, if from the start with the protruding tongue, isolated facial and airway edema, and it was not improving with any of your standard treatments for anaphylaxis. So, and we only hear about the rattlesnake venom playing around with bradykinin. Would you define this? Is this what you're defining as anaphylactoid?
This it sounds like he had anaphylaxis to the venom itself.
Okay. So I was looking at it. If it was not resolving with any of your standard issue anaphylaxis treatments, but he did get fresh frozen plasma, which is outside of C1, was it C1 esterase concentrates? That's C1 or fresh frozen plasma was a considered treatment for hereditary angioedema, pretty much unbridled, letting loose all of the bradykinins, similar to
tease that out a bit, right? So if I'm hanging out with Chris Davis and he gives me a piece of salmon and I take a bite, that's one bite, I'm anaphylactic to it. You start treating my anaphylaxis, that's only a certain amount of salmon that you got to deal with and neutralize, right? But if you are anaphylactic to the venom, and you only use a little bit of anti-venom, you have like this much anti-venom, you neutralize this much venom, but you have this much venom left unneutralized, you're still going to be treating. It's like half treating an opiate overdose with only a little bit of Narcan. You might need to redose it.
And considering this man's had the entire worth of a rattlesnake injected to his hand, I mean, if functionally IM and plausibly some of it's straight IV, hence his really rapid onset. The Crofab was the half-life, they state here is less than 12 hours, but you know better than this would. And the amount of time it would take to clear the venom itself is longer than that.
Yeah, so the half-life is shorter. The Crofab, and why it's so expensive, it goes to Australia because there's sheep there and it's an island, so they don't get mad cow disease. They cleave off the Ys. They can't do the YMC anymore, so it's just a little protein, so it can get to different areas. So it works. So it's a shorter half-life, but it reaches. But if you neutralize it appropriately more quickly, then the half-life, once it binds to it, it's bound, and you just pee out the neutralized venom. So by them kind of pissing on the fire a little bit, they never got control. They started to, and then it kind of finally fizzled out, and the venom stopped doing its thing finally on its own. But otherwise, they were actually, you had venom that was causing a major coagulopathy, and they were just dumping blood products at it, and that venom is just going to destroy those blood products. So in reality, they like until it's neutralized, you really actually don't even need the blood products, which is hard to think of when you have somebody that's bleeding out from their crike, their IV sites, their eyes, you're watching their labs go down. But when you get it properly neutralized, all of a sudden that bleeding stops, and then you see the numbers start to creep up, which is quite amazing to see. But it still comes down to you have a toxin that you need to neutralize with the antidote. The antidote for venom is anti-venom.
Oh yeah, so let's see, we got 6 vials to start, and I'm trying to find the timeline of. I don't have a timeline between.
Yeah, I counted a total of like 25, 26 vials, but it was like over the course of like 4 or 5 days.
That's not helpful. Well, it's helpful. He walked out. You know, any landing to walk away from, right?
Yeah, but you know that's scary. And he's lucky, crazy lucky.
Is there so is there any reason to not try an awake intubation on these patients? I mean,
that is a wonderful question, and I'd like to show you something to answer that question, if you don't mind.
Sure.
I'm going to show you 2 things here really quick. Let me share my screen. I have a gazillion things open. There we go. Share that. All right. I think you see a guy that's criked, right?
Oh yeah.
So this is a gentleman. It was his 7th bite by an eastern diamondback. Yes, I said 7th. He was fully anaphylactic quite early on and didn't show any. That was to the venom. And the docs later were afraid to give him more anti-venom. I'm like, he's already criked and bleeding out everywhere, and we were bringing him more anti-venom. He did great in the end. And then this was a cane brake bite that he was hypotensive on 3 pressors, tachycardic with ischemic changes, bleeding out from everywhere, but you couldn't even see any swelling or changes. This is a timber. This is a cane brake, which when they're younger, they're much more neurotoxic. And this is a gentleman that I gave 12 right away, another 12, another 12. He ended up with a total of, he's right-hand dominant, and he ended up with a total of 81 vials. But he went back to work as a blue-collar worker at day 8. no fasciotomy, no debridement. This is him on day 3. That's another Florida man. But this guy here, with regards to your question, this is typical Florida man. He was 13 T's. I won't get too political. I'll tell you later if you want, but he was bit on the tongue by a rattlesnake. And when they called me, this is another prime person, not to mention just if they're anaphylactic, I would try to nasally intubate them, or I would do DSI, awake intubation, do some ketamine, don't take their airway, get them down, and then secure it. For this one, when they called me, they said, hey, we got a 29-year-old male bit in the tongue by a rattlesnake. And I was trying to tell them, okay, nasally intubate him. But I got disconnected. They have video laryngoscopy. They put him down. They tried to orally intubate him. They were trying to gaff him. It was very difficult because the tongue was swollen from the Venomanol. You could see within 45 minutes from the bite, him bleeding from his nose. That's just his coagulopathy. In fact, these were his initial labs when he got to the hospital. If you notice that his platelets are 7, what should his platelets be? Like
More than
110,
more than 7.
150, right? So I could basically name each platelet after a dwarf with Snow White, right? But did he need a platelet transfusion? No, he got the antivenom. He got 12 vials, and then with the next hour, he got another 12 vials, and then he went to maintenance dosing. And you could see his tongue in the trach afterwards. And his wife thanked us, not because for saving his life, but she's like, oh, he's finally able to close his mouth again. So, so that's a long-winded version of, I love your idea of awake intubation or DSI to help control their airway. And I wouldn't be afraid, whatever drugs make you comfortable with doing that, absolutely do it. It's a terrific idea.
One practical point, something to consider too, that it can be when you have someone that's significant angioedema and you're trying to nasally intubate them, you can still have some like pretty significant swelling in the posterior oropharynx and things as well, that it don't expect it to be like a chip shot just because you're going through the nose though. You very well, that can be swelling all the way in the posterior oropharynx and still have trouble.
Absolutely.
Yeah. So you got, I mean, I would do it, but I would also have a knife in my other hand, like ready to go, you know, like that. I would just as a practical point, having tried to drive a scope around some big tongues before. So
yeah, that's a really great point. This is the arm of the guy that was bit the 7th time by the Eastern Diamondback. You could see he's already he's already a big guy. And it was already going to be a fairly difficult airway. But that's a great point by Dr. Davis, and great thinking in terms of awake intubation. There's nothing wrong with that. And I like that forward thinking.
Yeah, there's, what's the saying? It's like, you do one crake, you're a hero, but if you do more than one crake, maybe you're not good at airways.
That's a good point.
But there's I mean, I don't know. I've avoided many really bad airways that could have been craked through awake intubations. And, you know, if it doesn't work, you can still crake them. So
yeah.
All right, we should unfortunately move on if we can. I'm not sure if we can do both the next topics in the next half hour, but Mariana, if you will, can you tell us about your case? Maybe 10 minutes?
Can you guys hear me? Can you guys hear me? Okay, perfect. So hi guys. Yeah, I can probably do it in about like 10 minutes. Let me share my screen. Oh geez, I've never done this before. Share. Oh, it's not letting me do it. You want to pull up the PowerPoint?
Give me a second, but if you see the yellow button at the bottom center that says share screen, that should allow you to take over, but I will pull up your email just in case.
Give me 2 seconds. My computer has had issues. Hold on. Okay, there we go. Zoom. Oh, it's gonna make me quit and reopen. Glad. super glad. Let's see. Oh, hold on. Did this work? Can you guys see?
See your screen?
Yes.
Perfect. Okay. Okay, so it should be full screen right now, and let's go all the way back to the beginning. Okay, so this was an article critique. The article title is a randomized multi-center trial for crowfab, antivenom for the treatment of Crowlene snake bites in the US. So as we go along, this is just an outline of the actual paper itself. So the initial purpose of this paper was to basically compare the efficacy and safety of two different dosing regimes with crowfab. There really hadn't been any research in terms of dosing of antivenom, so this is one of the first papers to do so. And specifically, they were trying to see if crowfab was able to suppress the local recurrence, and it depended on which dosing regime we were going into. And I'll get into more detail about that. In terms of the authors of the paper, Dr. Richard Dart, he was an emergency medicine physician and specialized in toxicology. The rest of the authors all had very high backgrounds in toxicology as well, so very qualified. The study was actually done in 2001, so just keep in mind we're kind of going out of order. So keep in mind that crowfab maybe just came out. So again, a little bit of background. Venomous snake bites kill about 6 people per year. About 15 to 40% can have long-term sequelae in terms of like limb disfigurement or even death. So the therapy pre-2001 was basically supportive care, and that in terms of like the local tissue injury itself from the bite, hypotension, giving pressors like we talked about. And the only treatment before 2001 was a different antivenom called crotalid polyvalent. So this was only used in select patients because of the amount of adverse effects it has. I think about a quarter patients had anything from rashes to bronchospasm, and then about 50 to 75% of patients actually had serum sickness from the antivenom itself. So fast forward now, we have crowfab. The previous treatment was developed from like a horse serum that neutralized the venom. This one, crowfab, was actually made in sheep that were immunized to 4 different snakes. So we got the Western diamondback, the Eastern diamondback, the Mojave rattlesnakes, and cottonmouth snakes. And they basically isolated the antibody fragments from the sheep, and they discovered it was actually 5.2 times more potent. So basically, they wanted to create a trial and using this new crowfab to see if it was able to suppress the local recurrence and maybe have a better side effect profile compared to the previous treatment. There we go. Okay, so again, the hypothesis, we already stated that. In terms of it satisfying the components of well-defined research, aka PICO, so you have a population, which were patients that were bit by a crotalene snake and had minimal or moderate symptoms. The intervention was crowfab at a specific scheduled dose. We'll get into more detail on that in a second. Versus a control group, which was basically a PRN group after they were gotten into initial control, and they were not going to have any planned doses after that. And of course, the outcome was the termination of recurrence of envenomation symptoms, as well as maybe a lesser amount of adverse effects in terms of like serum sickness and such. So the design of the study was a prospective study. The groups were randomized. It was open label, so that kind of could be considered bias, or it could lead to bias because if you're treating a patient and you know that you're giving crowfab to the patient, you might be biased in terms of how you assess their improvement in the scoring. And again, just some inclusion criteria for our population. It was patients that were greater than 10 years old. They had minimal or moderate symptoms. People with severe envenomation symptoms were excluded just for the purpose of the study. And they had to be showing progression. So here's a list of our exclusion criteria. It's a laundry list, but again, like severe poisoning, copperhead snakes were actually excluded from this because it wasn't the original 4 that were in the sheep serum that they were testing, as well as like any history of hypersensitivity reactions and such. So in terms of the procedure of how they were creating the study, basically a patient came into the ER. If they met the criteria, they were enrolled, given a standardized assessment, and then each patient was given about 6 or 12 vials to achieve initial control of the symptoms. Once that was achieved, they were divided into 2 groups, the randomized to either the PRN or the scheduled group. And from there, various evaluations were done to monitor the progression or resolution of what was going on. So again, the PRN group had no additional doses after initial control, and the scheduled group received the 2 vials every 6 hours for a total of 3 doses. And this is just a list of the different assessments that were used. You can see there's a snakebite severity score, and this was just a way to quantify the clinical effects of the venom, like the coagulopathy that we were talking about. It could be swelling measurements of this local site. They did keep labs on each of the patients at various amount of hours and evaluated for acute or delayed hypersensitivity reactions. So they were followed up between 2 to 14 days after the study or after they were bitten. In terms of statistical analysis, just because it is a critique, you want a power of 80% or higher in a good study. So that means that there's a likelihood that the researcher will find a significant result and eliminate errors. So they calculated the study to have at least 28 patients and to have that 80% power. So the actual study was planned to have 30 patients. And then again, we already talked about the evaluations, and they were all statistically analyzed. So for our results, here's some tables, as you can see, just the demographics of the patients. A lot of them were white males that were bitten in the hand. I don't know if you can see my cursor. 24 of the patients, there's a total of 31. So most of them had the bite on their hand. So you're kind of wondering, oh, are these people actually going to catch the snakes, or is this an accident? So I just thought that was kind of funny. And on the right side of the screen, you can see the table. About 5 patients were lost to follow-up long-term in the 2, 4, 7, and 14-day follow-ups. So in terms of efficacy of efficacy evaluation in terms of initial control, we already knew this from a previous study, but CroFab was able to establish initial control. It was statistically significant, as you can see in the chart. It had a p-value of negative or less than 0.001. So we know that we can get initial control with the 6 to 12 vials. So the main thing we were looking for was, does it stop recurrence? So here, no patients in the scheduled group needed recurrence. That was the one that was getting the 2 vials every every 6 hours for 3 doses. But as you can see, 50% of the patients in the PRN group needed at least 2 vials during the first 12 hours, and that was also found to be statistically significant. In terms of the safety evaluation, so this is where we're looking for like adverse effects that were happening. There was no drug interactions in terms of like the opioids that we were talking about earlier that were given just for pain. But 6 patients developed acute hypersensitivity reactions, and this table is showing like the different reactions they had, either just like isolated urticaria, or if they had full-on hives and were wheezing. Some were given epinephrine, Benadryl to help with the symptoms, and all responded. In terms of serum sickness, that's what we're referring to as the delayed hypersensitivity reactions. 5 patients had the serum sickness, but it was later to be found that the batch of CroFab they were using in the early parts, because this study took place over 2 years. So the original batches had a flaw in the manufacturing step, which I guess it had these FC fragments still in there. And they think that's what was maybe causing the serum sickness. So after they adjusted this new purification step, only 1 of the subsequent patients had serum sickness. So that's good. In terms of strengths and weaknesses of the paper, there's in terms of snake bites, it could have a variability in terms of how they present. Like how we were talking about dry bites, either they'll just bite you and they won't inject any of the venom, or you could have a full-on bite with a lot of venom. injected. It's kind of hard to tell based on just the patient walks in the ER and they're like, oh, I got bit by a snake. So that's why the inclusion criteria and the evaluations were very specific in terms of what we were looking for. We were looking for the swelling to progress in order for them to be in the study itself. So I thought that was a strength. And then also the fact that we found a statistically different difference in between the groups in terms of keeping the recurrence rate down, which was also a strength. In terms of the limitations, we talked about the open label design, how it could affect the evaluation scores. And also the fact that they excluded severe envenomation. I know it's a study to show if it can actually help, but I mean, we have to know how to eventually treat severe envenomation as well. So that'll be for further research. So in terms of discussion, and key findings, so we established that CroFab can achieve initial control, and it helped improve the symptoms of patients in the first 12-hour evaluation period. We know that in the unscheduled doses were given in 50% of the PRN group, and no unscheduled doses were given in patients that had the scheduled vials every few hours. So again, this indicates that the repeated doses after initial control will likely be needed to provide adequate treatment. In terms of further discussion, so CroFab, its effects are actually more noticeable in the systemic components of the severity scores. So that means things that were affecting the nervous system, the coagulation, cardiovascularly in terms of like hypotension, CroFab worked a lot better. But in terms of the local injury, like the swelling or the ecchymosis from the bite itself, it said CroFab didn't improve that as much as the systemic components, which I thought was pretty interesting. And they said that was probably explained by the fact that like ecchymosis and edema are slower processes, or they're just less reversible by CroFab. And then again, we talked about the future research needed for severe envenomation. And in terms of why the pathophysiology underlying the recurrence, they actually aren't sure as to what causes that. They did speculate for potential causes. They think this first one is most likely what's causing it, and that has to do with sufficient venom was injected into the bite site and just continues to be absorbed into the body. And like we talked about, CroFab has a short half-life of 12 to 30 hours. So if this venom is still in your arm and the CroFab's already, after the 30 hours that's out of your system, the venom could just still be absorbed into the blood and then cause that recurrence of symptoms if you've already established initial control. They did speculate 3 others in terms of the venom CroFab complex, like dissociating. So again, that could, you have the redevelopment of symptoms. The different components of venom, they said could be affected by antivenom differently. And they also said that because it was developed from sheep, that they had antibodies may have developed and somehow caused the recurrence of symptoms. But they think the first one was most likely. And as the last slide, just for clinical context, again, so this was back in 2001. So this scheduled dosing guidelines is in our 2015 guidelines. And actually, we talked about the reconstitution profile, it being faster than the previous antivenom. And so that's more important if your patient is threatened airway or significant hypotension, it's not responding to pressors. So in final, the study had recommended, you have your initial 6 vials or an extra 6 to obtain initial control. And then you have your scheduled dose of 2 vials every 6 hours for 3 doses as needed. An additional 2 vial doses can be given if late recurrences of coagulopathy occur. Okay, how was that? Was that short enough?
Yeah,
That was good. Well said.
Really efficient.
Thank you.
And that, that as Drew had said, it's really good to look at where some of these the studies that some of our regimens are based on. And that was actually a really good review of that first article. The first of the main studies on it. There's there were a couple that were done right around 2001. It's interesting because before CroFab or after 99, Envenomations went up 243% of those that were reported before that to poison control centers. But the follow-up studies, CLIN 1, CLIN 2, post-clinical trials, or they were known as tab 1, tab 2. This is tab 1. But that's where they defined better in terms of it's better to do the required dosing or as scheduled instead of piecemeal. They got a lot more numbers instead of just being around the Arizona and Southern California poison area that encompassed more of the country. So it's really good to look back and see where things are from and see how they developed. And then it's important to go back and look so we can compare things. So well done.
Thank you. Also, I just realized I didn't introduce myself. I'm Marina. I'm a third-year med student. I'm actually from Alaska, so we don't have any snakes or anything like that. So this is a good intro to basically poisonous snakes.
Good trivia question. Which states don't have venomous snakes in the United States?
I know Alaska, but I don't know the other.
There are
ones.
3. Yeah.
3 states.
Yep. And
Puerto Rico count as a state?
no, not yet. Maine. Yeah. Hawaii, Maine, and Alaska.
There's got to be somebody with a pet.
Well,
I
know.
know that.
Native.
A friend of mine just published a book on snakes of Ireland. It's great. It's got a cover and a back cover, and it's a book full of empty pages.
Well, if anybody's up for it, I know we're near the end because I overpack things because I find all this interesting and I put too much into it. If Tyler, if you want to go through it, go ahead and run us through your case.
Hey, sure. I'll take like 5 minutes, like I said. So introductions, I'm Tyler. I'm a third-year medical student also in California. And the quick background, let me share my screen real quick. So the quick background is that I did MedWars Lake Tahoe just over a year ago. So during my second year in September, and it was a really great experience. And it kind of motivated me to create like monthly simulation cases is the ultimate goal for our emergency medicine interest group and wilderness medicine interest group. So the goal, COVID kind of halted things, but is to go out, do hikes, and run these simulation cases with the members. So that was the inspiration behind this case, and we've done it already. So this is a pit viper case. It kind of gives a good background really quickly. It's using the Stanford model for these simulation cases. They're posted on the EMRA website, which is great. And then the reference guide is from the Field Guide to Wilderness Medicine book by Paul Auerbach. So this is all the information. We've covered everything actually way more in depth than I did here. The audience for the simulation cases are meant primarily for first or second year medical students, but medical students in general, I suppose. So it'll start off right here. I don't know if you guys have done these simulation cases out, but my first experience was with MedWars, which is that off-road triathlon event that ties in medical wilderness cases. So the idea is that you give a brief scenario narrative. In our case, you'll have like a lone hiker who calls 911, and the wilderness medicine emergency group would go out and meet the patient. So as you see here, it's kind of broken up into various components. So right here on this end, it describes the situation. You have props that are associated, the environment, and kind of like any prompts, which would be down here that people evaluating the patient might miss. So once again, the idea is to just describe a classic patient with a snake bite. So you'll see a male, I guess it could be a white male since evidently most people who get bitten by these snakes seem to be white males, wearing shorts, t-shirts, 2 puncture wounds with redness and swelling outside the localized puncture wound site. And here are the initial vitals. So the scenario, of course, you start with the scene safety. So to identify scene safety, you want to make sure the snake's not around. It's taking place in San Bernardino National Forest, which is
kind of an environment right by us. After you identify the scene safety, you can do the primary assessment, which is right down here. As noted here, you can try to identify the snake and take a picture if possible, but it's not recommended to put yourself in any danger. The primary assessment, classically, is the ABC, so airway, breathing, circulation. And just for time's sake, I'll go a little bit faster than I normally would. But the idea is to ultimately do the primary assessment, then the secondary assessment, identify any symptoms such as nausea, faintness, things that might be associated with the snake bite. So as we discussed here, you want to identify pain or tenderness on exam and evaluate that evolution over time. You want to have the students measure initial circumference of the redness or swelling around the extremity or whatever area that's bitten, timestamp that and repeat that every 15 minutes. You want to remove tight clothing or restrictive garments, and so such as rings. And then there was the option to immobilize the extremity for the students. There's various prompts that you could give for the students. We kind of discussed pain management with contraindications being like NSAIDs, aspirin, et cetera, since it could exacerbate coagulopathies. From my reading, it looked like they recommended just IM opioids. So if the patient has extreme pain, you can administer the IM opioids, although I don't know if that's contraindicated in regards to evaluating the evolution of the pain over time, if that's such a sensitive marker of symptom progression.
That's a terrific question.
Yeah.
Treat the pain.
Treat it.
It's like a doubt. You're never going to get the pain completely under control enough until you give them the antivenom. So you'll still be able to discern the progression of the tenderness and the pain. Great question.
Cool. All right. And then ultimately, as we kind of discussed, the treatment is get them to the hospital as fast as possible, make a plan for a higher level of care. So get the helicopter or whatever the fastest means of transport and get the patient to a hospital that can treat them with Crofab or whatever antivenom they have there. And that's it, really. There were questions associated, but we've covered everything really well. So I guess this is just an example that I made for our local wilderness and emergency medicine interest group for students to hopefully learn kind of like an interactive way of wilderness medicine. So yeah, thanks.
Good job.
Great job. So that's the main content we've got. Anybody with questions or tips or cool stories?
Hello, I actually have a question for Dr. Abo, if he's still on. Hey, my name is Dag Shapchak. I'm one of the faculty members at UAB. Thank you for inviting our institution to join in this excellent journal club. Dr. Abo, everything here we've talked about stresses acute care, but one of the things that we've identified, at least in our state, is there really is a lack of follow-up care. So very few primary doctors are willing to see patients. So our toxicologist group here that is in our department basically has to do like telephone remote pictures from 3 hours away. What's follow-up care like in Florida, where I believe you practice? Do you guys run into similar situations, and do you have good solutions?
That is an excellent question. So I really take it upon myself, because I have the same experience in most places. For all the places that I consult on, I give the hospitalists, I try to empower the hospitalists and the patient, and therefore primary care, if they have follow-up, the knowledge, like simple, I'm like, hey, here's a resource, but this is what you're looking for, to give them that. And I actually have I just was revamping it. In fact, I have an info sheet that is very to the point, to give them for follow-up care, as opposed to the canned Epic or Cerner discharge paperwork that is not up to date. It's crap, and mostly it's you handing them a packet of, here, you throw this out, of legalese. But I do take it upon myself, because a lot of people they don't have the care follow-up, or because the physician, same thing like you said, they just won't see it. So, but it's really important for that follow up. In fact, in 2000 and I want to say it was 2012, we had a boy outside of Jacksonville. This was before I got involved with things, but he was lost to follow up care and ended up dying because he didn't follow up as suggested for the things. He was found, in full DIC. Very unfortunate. So it's really important to make sure, as the toxinologist or the ER doc, I make sure I stay through for the team for their discharge information, and I empower that info. And that includes the follow-up blood work, the restricted activities, and things like that. But I end up doing a lot of personal follow-up. I want more people to take it upon themselves. It doesn't have to be the scariest thing. It would be nice. I mean, even this weekend I had 4 snake bites, 2 cobras and 2 water moccasins.
Well, everybody's shown really cool pictures. I don't have any crazy exotic things, but within a week of starting my fellowship and moving down here, I had a copperhead bite, which run of the mill down here. The main thing that was really cool was the fact I had a dry bite on one side and a envenomation bite on the other. Sorry, the Zoom is kind of in my way of exactly where I want to get to my tab.
The same guy?
Same person. One foot was dry, one foot was in envenomation. There. So this is obviously the envenomated foot.
Is this a male?
No, she didn't fit all the T's. She was missing one, just one.
Okay.
So her right foot was obviously the envenomation bite. The left was a dry bite. She had fang marks on each foot. And you can clearly see the effect of a dry bite, probably some local swelling. I mean, technically she had some penetration from fangs, so there's probably a minute swelling at the site. And the other was obviously swollen starting at like the right medial malleolus there. And this, we might accidentally go to like personal pictures in a second, but I think it's just campfire stuff. But this was all the markings were done prior to transfer to myself from, I think it was Danville or Martinsville, Virginia, not too far. I'm in Southwest Virginia, and those are within an hour, I believe. So she had either 4 or 6 vials prior to me seeing her, and then the pain was essentially resolved by the time she got to me. And this is my first laying eyes on her. We elevated her leg from here, but it was just really cool that I had one side that was dry and one side that was dry.
That's really cool. I want to point out 2 things. This is great.
Yeah.
So one, if I stab you for not laughing at my jokes, or if you say crap about my curly hair and I stab you with a 21 gauge needle, you'll see a drop of blood. It's not going to swell that much.
Mm-hmm.
Like at all, right? I mean, so I see people that look like her right foot with all the swelling and the bruising, and they're like, oh, that's probably just the mechanical because they were bit. And I'm like, no, that's venom. Like, come on. The other thing I want to point out, they have the markings of the skin changes. And the only thing that I would do different is I would discern. I put a P for pain, T for tenderness, S for skin changes next to the time. And you can really see how well that progressed or even regressed. And I really like that picture of comparison to 2 foots, and you can see how from the bite site it's gone up.
Yeah, I thought that was really cool to see. I was luckily she was nice enough to let me take her pictures, and she had consented to using it for any educational purposes, so it's been great.
Dr. Abbo, you mentioned that you don't recommend calling a local zoo for antivenom. Was there a particular reason?
Yeah, it usually doesn't work. In fact, this weekend, that's what happened. Great question. So, in fact, the first snake bite I ever treated was when I was a paramedic in Pittsburgh. It was a cobra bite. Cobras are not indigenous to the U.S., Penguins are to Pittsburgh if you're a hockey fan. But so we called the zoo. But number one, the zoo has to have that species. So the Pittsburgh Zoo didn't have cobras, so they didn't have antivenom. Number two, you have to get a hold of somebody, right? Like it's really hard to get a hold of somebody or know who to call and this and that. Number three, even if you get a hold of somebody, they have the antivenom, they have to be willing to lend it to you. The whole reason why they have the antivenom is because one of their people might get bit.
Right.
So that's why venom banks were created. And that's why I have Venom 1 and Venom 2. There's a Venom 3 that has exotic stuff. He has crowfab and he has exotic stuff in another part of Florida. I'm trying to make him more national. And one of my bites this weekend was Tulsa. They were transferred. They called the 2 local zoos that didn't have cobra antivenom. So I helped them get it from I was about to send to them, but I helped them find, and Dr. Banner found them antivenom in Wichita. So it's 2 hours away. And so you get a hold of somebody, they have the antivenom, they're willing to give it up. Then you also have the fourth logistic. How the heck are you going to get it? Right?
So Ben,
yeah. Were you about to talk about our
I was
cobra?
about to say we could totally tell about the case that we had of the cobra envenomation in Lexington.
Exactly.
Yeah.
Perfect segue. So that one, another great example, was somebody that had a pet, and the guy's father, hypothetically speaking, was bit by this cobra, immediately symptomatic. Called poison control. They're trying to look around, call different places. This is one of the shops up there in Wake Forest. Lisa gave me a call and we were able to help them and I was able to help set up where they had antivenom closer than me. And this was in Myrtle Beach. And because of Dr. Chris here, we were able to quickly, and that person was on the ventilator. They were not doing well.
And
Chris was able to help us.
Community hospital that doesn't even have an ICU where this patient is right now.
Which Lexington?
Lexington, North Carolina.
Okay.
And Chris was able to help set up, ended up going by helicopter because of various things and weather, and we couldn't get it delivered and couldn't send somebody to go get it, but it was perfect and was able to get that. So we were able to get the antivenom up there.
We've got one of our Wake Forest helicopters based in Lexington and actually flew to Myrtle Beach to get the antivenom and then brought the antivenom back and then gave it to the patient and then took the patient to the main hospital. So,
wow.
Yeah. So, and it's interesting. There's, and that's why we had the venom teams and I helped set up. We had, I had 2 exotic bites in Michigan. We have up around Florida, obviously around the US, a lot of cobra bites. Cobras are the most common exotic bites, specifically the monocle cobra that we have in the US. If you look at historically, it's interesting. After 9/11, on September 12th, the only non-military jet that was in the air was actually carrying antivenom from the Venom 1 team for a taipan bite. But it's really hard to get a hold of anybody. Poison Control does have a list called Venindex. I'm sorry, Poisondex. So basically, it's supposed to be a list of what zoos, contact numbers, and what stuff they have. The problem is it might not be up to date and people change jobs and things like that. So your best bet is you can call Venom 1 24/7. You can call me. You can call, there's certain poison centers that are more apt to knowing where antivenom is around. If you're clinically working somewhere, I would try to just find out generally what the game plan is, what's going on. And if you're into wilderness medicine, I would know who has what around. I know in my counties, and I know all Florida, who has venomous pets, who has them for business, who has it for pleasure. Some of them, I work with them to get their own antivenom. Otherwise, we have our venom bank. So you can't just, we always talk about just calling the zoos, but it doesn't work. When I
think our case kind of shows that you kind of need to know a little bit before it happens, because had, we not known Ben, and like I've been involved with the helicopter and like all of those things, if that not happened, there's no way this guy would have gotten Cobra antivenom in like any reasonable amount of time. So I feel like you gotta have a plan before this happens, so.
Yeah.
So, Dr. Abo, for those of us who do live out in Oklahoma, where we have many, many snake bites, you were saying that you have a handout that you give for like their discharge and follow up.
Yes.
Is there any sort of reference or place that we could find something similar, or would you just advise us to come up with something for our own hospital and providers?
What I would suggest is I'll gladly send it to you, and I would bring it to your hospital administration and say that this is what you should be using, and you could either use it or adopt it. I don't care. But it's much more to the point, and it's better information than these hoopla, like the stuff that's canned that comes from these, because they buy it as a package.
Well, I will also say we use Meditech.
It doesn't make sense.
So we don't even have like nice Epic packets. And I say nice, like air quote packets. But yeah, like in July, first month of residency, I had to give Crofab 6 different times. So
I remember that.
We are well acquainted with snake bites out here. I'm not surprised that you got a call from Tulsa.
Yeah, no, I'll gladly share that with you so that you can adopt it. Basically what I've done for a lot of the places, like the places that I've clinically worked, I've brought it to P&T and to the CMO. I'm like, look, this is what you're giving out right now. This is what you should and why. And they have the research behind it. It's just a slimline thing, and it's more appropriate. And for mine, it has, the Venom team logos and my logo, but, and I don't mind if you use that as reference and stuff, but, yeah. And then when I consult, just like poison control centers they'll fax over this packet of like, here's the algorithm. But if you don't know how to really read the algorithm, it can be confusing. But I'm a little ballsier, I guess, because I want to just make sure it's easy to read. It's less legalese. So, yeah.
Well, we're 10. Could that document be emailed out to everyone?
Yeah, I'll share that in the thing. I see Frankie is asking how we get venom or anti-venom across the country. Yeah, I'll share those documents gladly to you all. How do we get venom across the country? We have the logistics already set up. I have MOUs in place with military, FBI, American Airlines, Delta. For certain regions, we have our own helicopter or the boat. It kind of depends. Sometimes I'll send a courier, sometimes we'll bring it. So there's a Cobra case 3 years ago in Michigan that we got anti-venom up to, as an example, also from Florida. So it kind of depends, but having the plans ahead of time helps. But that's, so we'll try and help set up the logistics also if something's not already set up.
Well, thanks everybody for staying over 2 hours. Just as an update for anybody who has stayed this long, and I'll announce it again at the beginning of next time. The threshold to get a free from credit is at least an hour of attendance. Even that is basically, if it's not a true WMS sanctioned event, this is like an WMS adjacent fostered event. It's 0.5 credits per hour. So that's why I went with 2 hours to basically give a full credit. So if you stay for less than an hour, I can't even give a half credit. But if you stay for at least one, I can kind of make the FOM committee kind of agree to give a full one. So thank you very much for staying the whole time. I think a couple people last time stayed for like 7 minutes and we're still wanting credit, and I had to tell them no. So thanks for staying. Anything else anybody would like to add or question? All right. With that being said, thank you very much, everybody, for joining. Thank you very much, Dr. Abo and Chris Davis. Thank you, everybody who joined and pitched in. Have a good night.
Thank you
Thanks
so
for
much.
having us. Yeah.
Thank you.